My name is Marianne Brodmann. I'm the head of the Division of Vascular Medicine and Geology in Graz, Austria. First of all, we have to say that below-the-knee treatment was not such an issue more than 10 years ago because we were mainly concentrating on the inflow above the knee and the iliac artery treatment. Right now, we see with this increasing amount of patients with critical lymphemia and below-the-knee disease that we also need to move from above to below the knee. And in the below-the-knee space, we were evaluating so many things like TCBs, which did not work, drug-coated balloons, which did not work. We had some kind of trials with drug-eluting stents. But the issue for below-the-knee in critical lymphemia with regard to development is that it takes so long to find the adequate number of patients to come to an adequate outcome. But anyway, right now, with specialty balloons which have been evaluated with new devices like the spur stent system, so there's development, especially focusing on the below-the-knee space. And so we have made improvement with regard to vessel preparation. What we still need is a working drug-coated balloon. And what is really right now the biggest asset are the bioresorbable scaffolds with the trials which have been presented here and have the positive data. The current landmark trial is for sure live BTK, you know, and this is the big hope for all of us. And this was really the big jump into a completely new area of treating patients with CLI and CLTI and below the knee. So bioresorbable scaffolds are sure in our hands right now the big asset we have for these patients. There are still some kind of discussions. Should we use it as a alone standing treatment or should we use it as a bailout? This will be hopefully clarified in the near future with a consensus of experts or guidelines or whatever. And you also have seen the next trial, which is really very successful, was very successful in the bioresorbable space, the presentation of the MOTIVE trial data. So with regard to this, we have right now 2 bioresorbable scaffolds who are really helping us to treat our patients better with better vessel prep tools as vessel prep before bioresorbable scaffolds. I want to have a drug-coated balloon. It doesn't matter what kind of TCB, what kind of drug on the TCB, on the balloon. I want to have a working drug-coated balloon because in some patients, you are happy just to do the ballooning and you do not need a scaffold. It's also a cost-effective issue in the different hospitals. So this is for maybe simple patients. And then you have the complex patients where for sure would use the bioresorbable scaffolds. The point will we use this as a first line or a bailout? This should be something like an expert consensus guidance. This is what I would like to have. And with regard to vessel prep, I think there's an ideal tool right now out there. This is the spur stent system, the retrievable spur stent, which is really showing that the vessel wall compliance is much better after that. So if we have this and add on a TCB which is working, and then for the bailout, a bioresorbable scaffold, I think this could be my daily life procedure. The final frontier of this space in the CLTI below the knee is that we still stop above the ankle. So we need to go down below the ankle because it's good to provide the inflow to the ankle area, but the patient is walking on the foot, and the patient needs the foot to be able to walk. And if the arteries are diseased on the foot level, on the plantar level, sometimes the inflow treatment is not sufficient enough. So if we clarify this issue here below the ankle, below the knee, we need to go below the ankle. And this is just the next area we need to evaluate.